Good evening. Welcome to our webinar. I'm Dr. Stephen Dayan, and I'm going to talk to you tonight about closed rhinoplasty, a method that I believe greatly in and I've been doing a lot of lately. I've been talking about it, writing about it, and I think I found some wonderful nuances and wonderful ways in which to employ the closed rhinoplasty method, and I want to report those to you today because we get so many questions about it. So let's go ahead and get started. Are you thinking of having a rhinoplasty? Is this something you've been contemplating for a while? And why? Are you looking for perfection, greater symmetry, improvement from a previous surgery? You have to think about all these things when you decide to undergo a rhinoplasty. And what are the goals of rhinoplasty? You have to keep in mind that perfection may not be possible, but getting a better nose certainly is within the realm of what you can expect. And I believe you can get there with the closed rhinoplasty. So if you're deciding to do rhinoplasty, if you want to make your nose look different, you want to make your nose look a little better, or perhaps you want to breathe better, what are your options? Well, there's two different options. There's surgical and non-surgical. And truthfully, the non-surgical methods, I don't believe a whole lot in. Occasionally we'll use some of these techniques, but for the majority of patients who want to make an alteration in their nose, the non-surgical method is not really the method that's going to be best. I published a paper a few years ago about using Botox in the lower one-third of the nose. And as you can see on this lady, the tip of her nose comes up a little bit by placing Botox around the nose. So we place Botox right around here, and you can see in this picture the nose comes up 5 degrees. So to raise the tip of the nose slightly, you can use Botox. You can also use filler to fill in the dorsum of the nose or the bridge of the nose, as you see here. It's another option. But once again, not a big believer in this. I do it occasionally, and I've done lots of them, to be honest with you. I've written lots of papers on it, but it's not something that I think is the first line option for those people who are seeking rhinoplasty. Generally speaking, the options are surgical if you want to go rhinoplasty. And rhinoplasty is by far considered the most difficult procedure to do well in plastic surgery. It's a challenging procedure. That's why the experience is very important. Your doctor's experience, in my opinion, is perhaps the most important question you can ask when deciding to undergo rhinoplasty. The average plastic surgeon, according to data that's taken off of American Society of Aesthetic Plastic Surgery website, the average plastic surgeon does between 12 and 14 rhinoplasties a year. We do 150 to 200 here a year just for measurement's sake. So I think experience is important. And if you're going to undergo rhinoplasty, there's two methods. The closed method, endonasal as we know it, is when we make incisions on the inside of the nose, so there's no outside scars. Versus the external rhinoplasty, where incisions are made on the outside of the nose. There's a small incision made in the columella, which is this region right here, across the skin between the nostrils, and the skin is flipped up over the tip of the nose and allows for better visibility of the nose. Now, rhinoplasty has many of its origins in around the 1900s. After World War I, there were many patients who had these horrible injuries. Rhinoplasty became a method to allow these patients to enter back into society by giving them a nose. And we learned a lot about rhinoplasty, and for 70 years, rhinoplasty was really done one way. However, problems developed from the one-way rhinoplasty was done. Here's a patient who had surgery to his nose. You can see collapse of his nose, difficulty breathing through his nose. Not a natural-looking nose. There's too many of these that were out there. Patients were getting rhinoplasty, and it wasn't done with stability measures to make the nose stronger or able to have better function for breathing. This became a problem. Well, the open rhinoplasty was introduced in the early 1980s by a doctor out of Toronto, and he presented on open rhinoplasty, and this great new wonderful method was offered to doctors. And it was a great way to see, because now with the skin up over the nose, you could see all the cartilages of the nose. Things were wide open. It became easier to put cartilages into the exact place you wanted them. You fixed them into place. So incisions made across the columella, as you see here, where there's this marker is. The skin is then flipped up over the nose, and you can see the cartilages of the nose. And this grew in popularity. This new technique became the way that everyone wanted to do rhinoplasty. But there's a concept to open rhinoplasty in which you have to deconstruct before reconstructing. And what that means is you take things apart, generally speaking, before you put them back together. So when we remove the skin off of the nose, we disrupt a lot of cartilaginous ligaments, a lot of important supporting structures to the nose, and it makes the nose a little bit weaker. So we have to rebuild the nose. So we're putting lots of cartilage grafts back into the nose. I don't want to scare any of you. So the next picture might be a little scary. So for those of you who don't want to see, turn away. Now I'm going to go back to the picture. So here's taking the septum out of the nose and putting it back into the nose. Now this is a pretty aggressive procedure through an open approach. So not every patient is going to have their septum taken out. But when you do an open rhinoplasty, generally speaking, you're deconstructing, you're taking the nose apart, and you got to put it back together. So what this means is you need a lot more grafts. And this is a graft, and this is me cutting the graft, and it shows you what we go through during the procedure. So we take that graft, and we get it from multiple different sources. We carve it before we put it back into the nose. So we make the nose stronger after we deconstruct it. There's not enough native cartilage within the nose. We need cartilage elsewhere to rebuild the nose. So where do we get it from? We may take it from the ear. What are the risks? Pretty slight. Pretty slight. The incision's made behind the ear, and it hides well in the crease, and it's rare for anyone to recognize we did much there afterwards. There's a risk of bleeding in that area, but once again, we've never seen that, so it's very unlikely. Infection and bleeding are common risks to any surgery, and those people who don't take blood thinners, such as aspirin, vitamin E, natural supplements, such as ginkgo biloba, garlic, ginseng, if you don't take those, the risk for bleeding is very low, and it's unlikely. So it's very important you tell your doctor if you're on any natural supplements or if you're taking aspirin or vitamin E. But having said that, let's get back to rhinoplasty. Occasionally we take cartilage from the ear. If we can't get it from the ear, we may have to take it from the rib, because rib is very strong, good cartilage, and when we're doing reconstructive rhinoplasty, we may borrow from the rib. It's not often I take it from the rib, only when I think it's absolutely necessary. Although small, there are risks of a dropped lung. There's other risks that go along with taking rib cartilage. So I tend not to take it unless absolutely necessary, but occasionally we have to rebuild the nose. And then we fix it in the nose. Once again, I don't want to scare anyone, so I'm going to go back. Now I'm going to come back to you. So we carve the cartilage, we put it back into the nose, and here it is inside the nose, fixated in place. And afterwards, the nose is stronger, it looks better, it's a solid nose. And sometimes open rhinoplasty is the only method to get someone straight and to help them breathe. This gentleman had multiple nasal injuries. The only way to get his nose straight and to get him breathing better is to do an open rhinoplasty and to rebuild it, because there's no way I can get to the most superior aspect of his nose, this region, unless I do an open rhinoplasty, because I need to be able to see up there. So he needs an open rhinoplasty. There's just no other choice. And after doing the procedure, he gets a much better looking nose, one that fits his face cosmetically, and also that functions better. But the downside is there's more bruising and more swelling. Because generally speaking, when you do an open rhinoplasty, it's a longer procedure. It generally takes anywhere from 2.5 to 6 hours. But usually it's about 3 to 4 hours when you do an open rhinoplasty, because you're taking things apart and you're putting them back together. Whereas when you do closed rhinoplasty, it's an 1.5-hour procedure in general. It's rare to go more than 2 hours with the closed rhinoplasty. So open rhinoplasty, generally speaking, is a longer procedure. Well, more anesthesia, more surgery, generally more swelling afterwards, more bruising. These are all things that tend to happen with open rhinoplasty. And it's one of the reasons why I've been moving more towards closed rhinoplasty, because I believe that the shorter surgeries, less downtime, less risks associated with it, I like closed rhinoplasty. And the results take a long time to achieve. We say with all rhinoplasty, it takes about a year to get the result. Because during the first year, the nose settles. Sometimes there's little lumps and bumps that come up during the first year, but not too often, but sometimes. So it takes a whole year until all things kind of settle and the nose is your final result. With open rhinoplasty, sometimes it can take even longer. I've seen it take 2, 3, 4 years before people get their final result. Whereas with closed rhinoplasty, because there's not as much swelling, not as much surgery, it tends to be quicker. Closed rhinoplasty allows me to do that. And after open rhinoplasty, occasionally one of the things that bothered me was sometimes the nose just didn't feel normal. Patients would tell me their nose, when they touched it, it felt hard, it didn't feel correct. Or when they wiggled their mouth or the nose, it just didn't move appropriately. Now it looked good in pictures, but it just didn't seem like their nose. It seemed like a totally new nose that didn't fit within the context of their face. So I've heard a lot of people say that. But most doctors, unfortunately, only trained in one method. We just did a study, and the paper's being published this month in Archives of Facial Plastic Surgery. It's going to talk about how often people are trained to do rhinoplasty and which method. And generally speaking, 88% of doctors are learning one method, open rhinoplasty. Or a majority of the time, they're learning just one method. So most doctors are learning just one way of doing rhinoplasty, that's open rhinoplasty. I think there's a role for doing closed rhinoplasty for more patients. So has the pendulum swung too far? Are there many patients who would benefit from a closed rhinoplasty, which is a quicker procedure, less downtime, and I think the stability can be there, and the strength of the nose can be there if done in a closed rhinoplasty. So my argument is, can we take what we learned from the open and do it in the closed and still get a wonderful result, a solid nose that's strong, but yet fits within the context of the patient's face, not a lot of swelling, not a lot of downtime. So yes, I believe we can take what we learned from the open, transfer it to the closed, and still get a wonderful result. So some of the techniques that I've been describing lately sandwich grafts, lateral crural extension grafts. These are types of cartilage grafts that I place into the nose that I learned through the open technique, but now I use in a closed technique, in a more modified version. And actually, I gave a talk in Australia to the Facial Plastic Surgery Society, and it's on YouTube, in which I go into more detail about these types of grafts. So if those of you who are interested in it, I refer you to the YouTube website, or you can call my office, and we have reprints of the articles and videos on how we do this. But I think it's a wonderful method to give strength to the nose, stability to the nose, yet at the same time make a nose look more appropriate. So here's a patient with multiple grafts. She wanted surgery, wanted her nose to look better. So I put in all these grafts through a closed approach. This is what her diagram looked like, because we diagram afterwards exactly what we do. Here she is afterwards. You can see the before and afterwards. So a nose that's more appropriate, it fits her face, her eyes brighten up. With rhinoplasty, one of our goals is to make the nose hidden so you can't see it as much, and it becomes just part of the face. And all attention gets driven to the eyes, because the eyes are the prettiest part of the face. So that's one of our goals with rhinoplasty, is to make it, but the nose has to be natural, because if it's not natural, people will recognize it. So a natural nose is more appropriate than just a cutesy nose that doesn't fit someone's face. Lateral view, and you can see that a more appropriate nose, one that fits within the context of her face, get it all done through a closed approach, and a few months later can look very nice. Another patient, thin skin, measures have to be taken to make sure she heals well. All types of grafts put in, but she just looks more appropriate. Once again, a nose that's similar to what she started with, but just a little bit better. Base view, wide nose, using special types of sandwich grafts. I'm able to bring the tip closer together, give a more triangular appearance. One, once again, that looks more feminine. Here's another patient, curved nose. In the past, we'd have to open this up, do a total septal replacement, 4 hours of surgery, rib cartilage grafts. No, now I do a close. Slip in a few grafts through some closed methods and precise pockets. No ear cartilage is even needed. Straighter nose, one that looks better quickly after surgery. 3/4 view and lateral view. Another patient, curved nose. I'm able to put caudal septal extension grafts. So these types of grafts that are more detailed than you may want to know, but can be done through a closed approach. Minimal edema, minimal swelling, minimal bruising. Looks good a year later. So it can also be used in revisions. In the past, we thought patients like this who have a high arched ala, alar retraction, and short nose would need an open rhinoplasty. I did it closed. Put in a few grafts, he looks good a couple weeks later. In the past, revision rhinoplasty would be even a longer procedure, almost always was relegated to rib. It would take 6 hours, 5 to 6 hours, have to put in cartilage grafts, have to carve cartilage grafts. No, now I found new ways of doing it through a closed approach, and I can make the nose look more appropriate without much downtime or swelling. And he's very happy. The key is that he's happy. My goal is to make my patients happy. It's not necessarily to make me happy, it's to make my patients happy. What does my patient want? Everyone's different. Well, one person thinks looks good, another person doesn't. So I need to find out what my patient wants in order for them to be happy. 3/4 view, base view. And he can also breathe better. If you look closely here, you see he's collapsing. Afterwards, his nostrils open. He's able to breathe a lot better as well. He's thrilled because for the first time he can breathe. And breathing is one of the most important parts of rhinoplasty. We have to pay attention to the breathing function. Closed rhinoplasty, once again, revisions procedure, use closed rhinoplasty techniques to be able to make it better. So technically, closed rhinoplasty is a little more difficult to do. Absolutely. So it's important that you have a surgeon who's experienced. Generally speaking, it's a person who's trained in the open and they have a lot of experience before they go into the closed. It takes a while before someone has the capability of doing a closed rhinoplasty well, because you can't really see in there as well, so you have to know where you're at. So experience matters here a lot. And they must have good hands. They've got to technically be good. They have to technically have hands. They're good. They have to have an artistic eye. You have to be able to see in 3 dimensions. And they have to understand your desires. The most important thing is making the patient happy. And as I said before, some people want a total change, some people don't want to change at all. So if we understand your desires, almost always closed rhinoplasty is the way to get there. I believe that most people want to have a nose that fits their face, that looks natural, that's not obvious. Occasionally I get someone who says, "Doctor, I want a totally different nose. I don't care who knows about it." But that's unusual. Most patients want a nose that's similar to what they already have, just a little bit nicer and more defined. So one of the things I do is I put pictures up on a computer, and I can find out afterwards. I can show you kind of what to expect. It's not 100%, but it gives you some ideas. Either approach, open or closed, can get you a great result. Either approach gets you a great result. the key is the physician. You've got to be happy with the physician. Some physicians do wonderful work with open, great. But generally speaking, it's a longer procedure, more downtime, more likelihood that cartilage grafts will be needed from the rib or the ear. Ultimately, you have to be happy with the doctor and comfortable with the doctor and with the staff, because you're going to be in and out of that office quite a bit over that first year. Lots of phone calls, you're going to be working with the staff, you're going to be working with the doctor. You want to know if that doctor's going to be available, you want to know if the staff's available, you need to feel comfortable. It's got to feel right for you. And then once you make the decision, be confident in your decision and move forward. For those of you who have more questions, I refer you to our website or call my office. We can send you DVDs. Or YouTube, there's been some videos of me giving talks in Australia that you can download as well and look at. I hope you enjoyed this. Thank you for attending tonight, and I look forward to hopefully seeing any or all of you.